Hello everyone, welcome back. Today I'll be covering fracture femur in children. We start off with an introduction, mechanism of injury, clinical presentation, radiographic assessment, classification of fracture, management of pediatric femur fracture. I hope it helps. Now let's get started. As an introduction, the femur is the largest bone in the body. Pediatric femur can be divided anatomically into A. Proximal femur consists of femoral head, femoral neck, greater and lesser trochanter. B. The femoral shaft can be divided into proximal third, subtrochanteric, middle third, mid shaft, and distal third, including supracondylar and intercondylar. C. The distal femur, medial and lateral epicondyles, the medial and lateral condyles, and the trochlea. This figure shows the femur anatomy. As discussed before, the proximal femur, femoral shaft, and distal femur. There's a femoral head, femoral neck, greater trochanter, lesser trochanter, subtrochanteric region, then the femoral shaft can be divided into proximal third, subtrochanteric, mid shaft, and distal third, and distal and femur, including the lateral and medial epicondyle, medial and lateral condyle. Mechanism of injury. High energy is required to fracture a femur bone. While this is true for transverse fractures, spiral fractures may result from falls in ambulatory children, especially when they occur with a rotatory force. The specific mechanism of injury is most often related to the age of patient. For infants and toddlers, fall and child abuse are the leading causes of femoral shaft fractures. Red flags for child abuse among young children, especially when they are aged less than 4 years old. This figure shows how a spiral fracture occurs with a torsional force. This type is a stable spiral because it is still in contact and barely out of place. Mechanism of injury in children and adolescent. For toddlers and school-aged children, the main cause is fall. At this age group, even trivial and low-energy injuries such as fall from a low height or fall while running, this may result in a femoral shaft fracture. In teenage children, motor vehicle collision or sports-related injuries is the causative factors. Patients with predisposing disease, example, osteogenesis imperfecta OI, or other reason for generalized osteopenia such as cerebral palsy, spina bifida, or other neuromuscular problems at a higher risk for femoral fracture. Regarding clinical presentation, there is localized tenderness and swelling over the affected femoral shaft. Obvious deformity, shortening, and/or crepitus on palpation are usually present. For proximal femur fracture, there would be pain in the hip joint and/or a characteristic externally rotated leg position. skin is inspected for any open wound that lead to open fracture diagnosis. A careful neurological examination distal to the site of fracture before and after splinting is important to ensure that the displaced fracture has not damaged the nerve or arteries. This figure illustrates the external rotated limb and the affected leg is shortened. Need to rule out other concomitant or life-threatening injuries when associated with high-energy trauma. Waddell's triad by Dr. Mercer to describe a common pediatric injury pattern when young patients who are hit by a motor vehicle when they run into the street. This pattern includes femur fracture, severe head injury, and thoracoabdominal injury. For radiographic assessment, standard anterior-posterior epi and lateral plane radiograph of the entire affected femur from hip joint to knee joint are necessary to identify the fracture. Based on X-ray, the deficient location, whether proximal, middle or distal third, configuration, whether transverse, oblique or spiral, the angulation, amount of displacement, presence of comminution, and extent of shortening. Or we can classify it of the fracture into A. Descriptive by Egol 2010, whether the skin is open or closed, the level of fracture, whether it's proximal, middle or distal third, the fracture pattern, whether it's transverse, spiral, oblique or butterfly fragment, the level of fracture comminution, the level of fracture displacement, the angulation. Or B. Anatomic, based on location, subtrochanteric, the shaft or supracondylar region. This figure shows the classification of fracture, whether it's transverse in nature, linear, oblique non-displaced, oblique displaced, spiral fracture, green stick fracture, or comminuted fracture. Regarding management of pediatric femur fracture, based on age, fracture pattern, location, soft tissue trauma, and other associated injuries, the American Academy of Orthopedic Surgeons summary recommendation. Based on age, if less than 6 months, the treatment option include pelvic harness or immediate spica cast. For 6 months to 5 years, we can do an immediate spica cast or traction for a few days or 2 weeks, then convert to spica cast. This picture illustrates the pelvic harness. For the age 5 years to 11 years, we can do a flexible intramedullary nailing. For 11 years to maturity, we can use either rigid intramedullary nailing, submuscular or open plating, or flexible intramedullary nail. This figure shows a flexible intramedullary nail. In my hospital setting, we are usually use the titanium elastic nail system. We call it TENS. Complications can be divided into pre-operative and post-operative complication. For pre-operative complication, the fracture ends causing a nerve or vessel injury, infection that lead to superficial or deep surgical site infection, the implant prominent or extrusion with the use of flexible intramedullary nail that may need patient for reoperation, complications that arise from altered pathophysiology and anatomy related to the fracture itself, and prolonged immobilization include vein embolism, venous thromboembolism (VTE), and obstructive compression of the duodenum by the superior mesenteric artery, or we call it a body cast syndrome. For post-operative complication, these include bone shortening, bone overgrowth, both that lead to limb length discrepancy, malunion due to angular and rotational deformity, and non-union, but it is uncommon in children. Minor discrepancies in the length, rotation, and angular deformity are generally well tolerated. In younger children, these deformities may resolve spontaneously with growth. For limb length discrepancy, if predicted differences around 2 to 5 cm, contralateral epiphysiodesis performed prior to skeletal maturity. Osteonecrosis of the femoral head in a skeletally immature patient who had a rigid femoral nail placed through the piriformis fossa. The primary blood supply to the femoral head via the lateral epiphyseal vessel is interrupted by rimming through the piriformis fossa. Recommended usage of greater trochanteric entry nail. Treatment with external fixator will result complications that associated with this method. Example, a pin tract infection. Yay! We have reached to the end of this video. I hope it helps. See you in the next one. Take care and bye.